Hello and welcome to the Center for Optimizing Rural Health's webinar, Managed Care Contracting for Rural Health Organizations, presented by Jean Gochi. We are pleased to have you joining us today, and we look forward to your comments and questions, but for now, we have muted all participants. There will be a Q&A session following the presentation, and we do encourage you at that time to unmute or type your questions into the chat box, whatever you're more comfortable with. There will be a Q&A session following the presentation. I just let you guys know that I'm sorry. We will be sharing the slides following the presentation. So we will send out a copy of that along with a very short survey after the presentation. And if I didn't introduce myself, I am Cassidy Avila, and I would now like to take this opportunity to introduce our esteemed speaker, Ms. Jean Gochi. Jean is an executive leader and strategic consultant, helping organizations set new strategic and operational objectives, rebuild revenue cycles, and enhance performance and outcomes. Jean has a deep range of operational and strategic expertise developed over more than 25 years in her roles as a CEO, CFO, and COO in the healthcare industry. She has a proven track record of improving organizational performance in a wide range of settings, from physician groups to academic centers, nursing homes, home health agencies, and community hospitals. Healthcare finance is one of Jean's strengths. She goes far beyond the standard accounting and auditing procedures in establishing excellent financial operations for her clients. Her finance background is enhanced by her work as the Director of Business Development at Blue Cross and Blue Shield of Iowa, where she was involved in PPO, TPA, and HMO advancements. At the University of Iowa, during significant managed care growth, Jean built a revenue cycle system and achieved excellent rates for all hospitals and clinical specialties. This revenue cycle system received perfect scores by outside auditors. Jean has successfully mentored management teams through periods of instability. She has helped organizations reestablish working relationships with boards and physicians and address community concerns. Collaboration is a hallmark of Jean's approach, so much so that she has been recognized nationally for her work. She has received the Health Resources and Services Administration Award from the United States Department of HHS for meeting Oregon donation breakthrough collaboration goals ahead of schedule. Jean holds an MA in Health Administration and a JD, both from the University of Iowa. Welcome, Jean. We're so glad that you're here with us.
Well, thank you so much, Cassidy. And I want to thank both Cassidy and Bree here in allowing me to reach all of you regarding managed care contracting, which is a piece of revenue cycle and financial management in a healthcare organization. And I especially have worn, kind of a green outfit today because this is kind of my series of educational work that I do called Follow the Money, Honey. So, and this is just a small part of what is going on in healthcare finance. And what I find, I'm really glad to have everyone here who's on this conference, this webinar, because what I find is that the folks in the C-suite and even the CFOs oftentimes are not totally understanding all of the management issues that there are in the financial functions in healthcare organizations, in particular regarding accounts payable and vendor contracting there, and perhaps even more significantly in revenue cycle, of which managed care contracting is a part. And I'm going to tell you, in the interest of following the money, honey, tell you the three things that I want you to take away here today, for sure, because this is going to be such a fast session that we won't be able to get in depth on much of anything. So one of the first things that I want to let you know is, and this is how I got a perfect score on that audit back in my University of Iowa days, is that all of the managed care contracts that I negotiated, I collaborated with finance and other areas like pre-auth and that kind of other operational areas, so that we were getting paid what our contracts said we should get paid. And so this is a real takeaway here. No matter what else you do on managed care contracting, one of the most important things you need to set up in your organization is making sure you're getting paid what you are deserved to be paid. And I'll tell you a little story about that in what I see in financially troubled healthcare organizations is that sometimes they can't even find their managed care contracts. So one of the things that you should do today, and I believe we had it in the introduction to the course as well, is find out where your managed care contracts are and who's managing them. And I would say virtually almost 100% of the time in a troubled healthcare organization, you can't find the managed care contracts. And so don't be one of those organizations. Find your contracts and see what's going on. I had one sad case where even the Blue Cross contract had not been updated and renewed in 14 years. And of course, when that's going on in your revenue cycle process, who knows what you're getting paid? And I think some payers can take advantage of that and pay you anything, and you wouldn't know the difference. So find your managed care contracts, and the takeaway is make sure somehow in your system that you are getting paid what you deserve to be paid in these managed care contracts. So we'll go to another takeaway. The second takeaway is one of the most important things in a managed care contract or any contract, I find, is your out clause, the clause that the terms that allow the organizations to terminate the contract. And the lesson here, I learned this decades ago, the lesson here is to make sure you can get out of the contract fairly easily when you want to. And this is important in your vendor contracts as well. You know, these big companies, you know, it's a little bit of David and Goliath. And in the rural settings, you know, we've got David, and then we've got all of these big vendors like GE and Blue Cross and Humana that have these corporate offices and corporate attorneys that are negotiating these contracts. And one of the things that you can do to protect yourself, being David, is to make an out clause that's fairly simple. And what I try to do is make it an out clause that's reasonable for both parties in terms of how long it takes to get out of it. And then the second part of that, so let's say it's, 6 months. And then the other term on that is to negotiate that you can terminate the contract in 6 months for any reason. And usually that's for either party. And so you don't have to, sometimes the big companies will put in all kinds of legalese on terminating a contract and makes it very, very difficult. And if you find that a provider or an MCO or a Medicare Advantage plan just is not working for you, you can use this simple out clause to just get out of it. The third thing I want you to take away, and then we'll start buzzing through the material, is that with value-based contracting, the amount of data that needs to be collected and the involvement of everyone in the healthcare organization is a new phenomenon. And I've got another story there too. So when they're collecting value information like your infection rates or outcomes on certain procedures or whatever it is, the provider all of a sudden is expected to be collecting all of this data to demonstrate that they met the value outcomes that are proposed in the contract. And I used to say that revenue cycle involved everyone except the housekeeping. And now it even involves housekeeping to the extent that infection rates and infection control issues may be addressed in your value-based contracting. And in the value-based contracting, here's a story on this one. I was in another troubled healthcare organization, and we had a rural health clinic, and the local Blue Cross plan was fairly aggressive in starting to do outcomes expectations and value-based reimbursement. And it was really nice because it wasn't a takeaway type plan. It was if you met the value-based requirements that you could get a big bonus. And in this case, we'd actually met the requirements and got like a $250,000 bonus, which is pretty nice for a small rural health clinic. Well, so my new clinic director and I were meeting with the director at the Blue Cross plan, who came to visit us to take a look at our program and update us on what they were going to be doing differently in the next year. And it dawned on the three of us at that meeting with the Blue Cross representative, that the data that had been supplied was, say, not tied to actual behavior. So someone had, under pressure, provided the data that would meet the scores that Blue Cross had, and we got paid for it. And I've never been so embarrassed in my life, and in a professional setting. And the Blue Cross representative was so kind, because obviously we were figuring this out right there in front of her, and we made a commitment to make that right. And in fact, they didn't fine us or take the money away or anything like that. So, but what we're seeing here gets us to the third thing about takeaway that I want you to have is that when we're setting up managed care contracts, it isn't just a matter of signing the contract and putting it in a file. We have to let everyone know what they're required to do under the contract and provide them the support and the tools, IT, paper, whatever it is that they need to meet the terms of the contract. And so managed care contracting really involves a lot of facilitation across the entire organization, so that you aren't accidentally submitting data that doesn't tie to reality. We don't want anybody doing that. And actually, there's a fourth takeaway I want you to have for sure, and we'll start cruising through the slides, is that I have some resources for you in the last 2 or 3 slides of really good resources to get more in depth on your managed care contracting work to the extent that you wish to do that. And it includes, in particular, help from Healthcare Financial Management Association, which is a wonderful organization, and anybody who's involved in healthcare finance really would find it to benefit to be a member of HFMA, Healthcare Financial Management Association, because they do have so many wonderful tools and education items. So let's get started through the slides now, Cassidy, and we'll go to the impact of managed care contracting. I think it's about the 3rd slide in. Let's go another slide, please. As most of you probably know by now, managed care contracting is covering almost everything that healthcare providers are doing now in the hospital and physician settings. And 75% of the American population is in actually some kind of managed care plans. And the purpose of these managed care contracts largely are to manage the quality of care and also control costs. When we go to the benefit side for the consumers, and most of us have seen this by now too, we have our cost can vary with our benefits as a consumer based on how much provider choice we have, and then also on the amount of deductibles and coinsurance that we're willing to pay out of pocket. Next slide, please. Well, this is very quick. I think I'm not going to spend a lot of time here, but we all are familiar with the common benefit plans by now for the most part in most markets. Health maintenance organizations, preferred provider organizations, and point of service organizations. Next slide, please. We also are all pretty much familiar, I would think, that these managed care contracts come in many different forms, and they apply to individual physicians, physician practices, hospitals, hospital-employed physicians, provider networks, accountable care organizations, and integrated delivery systems. So your managed care contractor can involves various ones of these organizations. And actually, some of what I find confusing and sometimes difficult to manage is, say, a particular PPO, for instance, contracts with other organizations. And there's where you want to know who they're contracting with and what the beneficiary ID cards that are going to come in, so that you even know what patient benefits apply to which of your managed care contracts. Because sometimes one PPO in a market will actually sell their networks, if you will, to other bigger companies that may not be as big, particularly in rural areas. So they'll just kind of piggyback onto some of the more local, larger managed care companies in your markets. Next slide, please. And we also probably know that there are all kinds of organizations that are payers. And we have the Blues, we're used to the Blues. We have managed care organizations. I know in my market, I happen to be up here in the northern Midwest, here in Iowa, that our Medicaid expansion program, for instance, brought in Medicaid managed care organizations, and that the MCOs vary almost annually on that. And we've had as few as one Medicaid MCO, and now I think we're back up to 3. And so there's a lot of change in that Medicaid managed care organization piece in some markets. I'll just say that for Iowa. And then sometimes you'll actually have employer groups that will self-insure and develop their own networks, or may develop a network in partnership with, say, the local Blues plan or a local third-party administrator. And actually, if you can negotiate with your local self-insured employers and groups, that's not a bad thing to do, to control more what's happening in your local market, and to have a stronger leverage and a stronger seat at the table when you're talking about the beneficiaries in your region. I also want to talk about Medicare Advantage. Medicare Advantage, I'm just going to put a note of concern, kind of a red flag out regarding Medicare Advantage. I think what's going on is some of these Medicare Advantage plans, which these are plans that take on all of the Medicare reimbursement and for a particular named beneficiary. So they are taking on all the risk for the Medicare beneficiary through this Medicare Advantage plan. And many of these companies are for profit. And of course, to make money, in order to keep my, say, have my Medicare reimbursement, or what I'm in quote unquote insured for, I'm sure that's not quite the right term, but let's say Medicare provides the Medicare Advantage plan $12,000 for me in a year as a Medicare beneficiary. And they give that $12,000 to the Medicare Advantage plan, and then they in turn are going to provide all of my benefits. Well, as you might imagine, as a for-profit company, they're not real interested in spending all that money on me as a beneficiary. So they're putting in all kinds of things to save money and coordinate care, and some very legitimate things in some cases. But I'm also wondering if they really don't contract with rural providers, us little Davids out here with our slingshots, and they are just paying you whatever they want to pay you, which is sometimes at a Medicaid level or even lower. And then they also have very convoluted managed care terms. It becomes difficult to keep up with the pre-authorizations, or they may deny all of your claims. And then when your revenue cycle staff goes in to work on them, they're talking with someone who doesn't know their English very well. And you just end up writing off a lot of these Medicare Advantage claims. The other part of this that's out there is that the rules for the Medicare beneficiary are constantly changing. And I believe, I'm not absolutely certain of this, but I believe that if, say, I'm on a Medicare Advantage plan and I love it because I'm getting free tennis shoes and a gym membership, and and I may be paying no premium like you would on a Medicare supplement. And all of a sudden, let's say I get a complicated cancer and I want to go to the Mayo Clinic up here in Rochester, Minnesota, or maybe you in Texas would want to go to MD Anderson. Well, the Medicare Advantage plan may make you jump through a lot of hoops as a patient to do that, and you may not even be allowed to go to some of those places. And then the clincher with it is that if I try to switch back to original Medicare and a traditional Medicare supplement product, that at that point, because I've got a pre-existing condition with this cancer, I may not be allowed to go back to the original Medicare and MedSup when I want it then. And then or you may be allowed to go back on it, but they won't cover you for the cancer for some period of time as a pre-existing condition. And so there's a lot of issues out there with these Medicare Advantage plans, and it changes all the time. And I just wanted to point that out to you who are mostly in rural markets, I would imagine, to take a look at what's happening with your Medicare Advantage. And perhaps you should get involved with your local insurance agents or your senior. I know here in Iowa, we have the SHIP program, which is run by the Iowa Insurance Division to guide Medicare beneficiaries on their choices in Medicare and Medicare Advantage plans. And perhaps you'll want to get involved and make sure that you do have all the facts straight about what's happening with Medicare Advantage in your local region, and that your local community is understanding all of the fine print, because it's not just all about the free gym shoes and free meals and no premium. So that I wanted to point those two things out. Medicare expansion also here in Iowa, and I don't know what you have experienced, but our healthcare providers are almost in a depressed state about getting paid at all from these Medicaid managed care organizations. And so, that's something, again, if you're doing the managed care contracting, the leadership there should have an awareness of what's happening with your Medicaid MCOs, if you have them, and how you can best work with them and make sure that you're getting paid as what you deserve on these things, or even to decide not to participate, which is kind of a big deal, but and most of us can't afford to decline to participate. So I'm going to skip several slides here, Cassidy, and I want to go to the one, we're still on Roman numeral 1, and impact of managed care contracting, and I want to talk briefly about what's new and what's yet the same. If you could go to that slide, I think it's a couple away yet. There's a question mark on it. Next slide, please. There we go. So the purpose of managed care contracting remains the same from when it originated, and that is to control costs and to manage the quality and the outcomes of care. So that's all the same. And what we're seeing, however, is that the level of sophistication in doing those two things by the managed care companies just is increasing at a phenomenal rate. And this is some of what we're seeing in troubled revenue cycle organizations too, where there just isn't being addressed. And let's say, of your private carriers, say you've got 30% private carriers, but they're all under managed care contracting, and the organization is not really managing these contracts. You can see where that can, and the contracting companies are just paying you whatever they want because you're unable to grab on to the terms of the contract and make sure you're getting paid what you should be paid, and that they're doing pre-auths appropriately and those kinds of things, so that you I mean, that they're being reasonable and working with you. It's just become more detailed, more difficult, and there's more data and more work process involved all the time. And so if you're at a point where you haven't been able to find your managed care contracts yet, still that's the first step. And then it would be focusing on some of the things that we're going to talk about today so that you can improve how you're getting paid by these managed care organizations. If we can go to the next slide. Thank you, Cassidy. We're going to talk about the dynamics of the relationships between providers and healthcare organizations and managed care organizations. And again, probably the bottom line thing is here that most of us in rural markets are in a David and Goliath position. And we're David, and we don't even have any rocks for our slingshot in some cases. So if we go to the next slide, we can see some of the topics that we need to take a look at. And it becomes, I think, a choice of the provider leadership as to which of these they're going to make the most important. Because I think as small organizations, number one, you probably aren't going to be able to get very far with the managed care organization in making a lot of demands. And so you probably want to think about in your market, where are the managed care organizations, being more reasonable with providers and, take advantage of that if it exists. For instance, who would have thought that the Blue Cross plans would actually be some of the nicer people we work with in managed care contracting? And I think they really are, because they tend to be regionally based, and they have some community involvement in their regions. And so actually they do want, sometimes it's hard to tell, but they do want providers to survive in the communities in their markets. Whereas a for-profit company based in Tennessee or Minnesota doesn't really care about the providers in Tennessee or Texas or Missouri. So take advantage of really probably your local Blue Cross plan or a local third-party administrator that may be doing the administration of benefits for your local employers, because your local community is going to be the part of the managed care milieu that's going to care about you as a provider. And if you work with them reasonably, they're more likely to work with you reasonably and make sure that you can survive a managed care situation. So here we start, of course, the terms of payment are very important. And then I'm finding in the rural areas that we really don't have a lot of clout on the payment piece. And we really are at the mercy, if you will, of, again, the regional and community managed care organizations that want and need healthcare providers to survive. Another big area, and this one actually I would probably try to grab a hold of if I were a rural leader in managed care contracting, and that is how they're doing their utilization management, their pre-auths, their length of stay, the coordination of care. And the reason that I say that is that I am seeing, again, in the troubled healthcare organization, that the managed care payers are changing what is needed for pre-authorization and what types of care is needed for what types of care are being pre-authorized, required to be pre-authorized. And so, for instance, a managed care payer may actually require pre-authorization for certain very expensive pharmaceuticals. And then next year, maybe they'll do those pre-auth requirements for different pharmaceuticals. Or all of a sudden, there'll be some kinds of procedures such as infusions or other expensive things done on an outpatient basis that all of a sudden they're requiring pre-authorizations. And what I see in troubled organizations is that, again, the managed care contracts are sort of in a mystery corner somewhere, hidden, don't know where they are. And the staff in, say, the ambulatory surgery center or the cancer clinic are left to deal with these changing pre-authorizations. So, for instance, I found an RN that should have been, really working more clinically with the cancer patients, that was basically using up all of her time to handle the pre-auths from managed care organizations. And that's really not an appropriate use of clinical resource, an expensive clinical resource, if you ask me. So understanding what the managed care provider is requiring of you, particularly in, I think, the pre-authorization area, because if you don't get the pre-auth, of course, the claim is going to be denied. And sometimes I've had a little luck getting retroactive pre-authorization and get some payment through when I've, begged and pleaded. But you're really setting yourself up for particularly kind of expensive procedures and pharmaceuticals where you're not going to get paid if you haven't set up a good process for your pre-authorizations. Also, we talked a little bit about record keeping and the issue of all of the data, the new data that the value-based contracts are requiring us to collect. And I've seen this in very small rural settings. In fact, it was a very small setting that somebody was just plugging in the data to get through the day, unfortunately. And there was no clear documentation that the work that had been documented or documented had really been done. And so that whole record keeping piece, a managed care leader needs to be working with various clinical folks who are having to keep track of this data and make sure they have the tools and ability to do that. Another new thing that's out there, we're all familiar with HIPAA and confidentiality practices regarding that. But one thing that actually I learned here in preparing for our presentation is, because we're accepting credit cards now as payment in many healthcare organizations, there's another set of standards called the Payment Card Industry Data Security Standard that we also have to comply with. And I think, you could get advice from your attorney or say a local bank or something on what that is. But we also have very important data security requirements just because we're accepting credit cards. Then, of course, there's just the small thing of the clinical decision making and what are the standards of care that the managed care company is requiring. And I'm a big proponent that physicians should be able to practice within their range of practice. And I really have problems with totally cookbook standards of care. I think the cookbook standards are good to have in place as guides, as long as there's freedom to for the physician with his or her knowledge and experience to be able to do what they believe is necessary and following the science for their patients. On the next slide, Cassidy, we're talking a little bit about, again, still the dynamics of the relationship between the provider and the managed care organization. And we should have the common goals of standard and achievable quality of care measures that actually can be measured and kept track of and documented. We should all be interested in collecting timely, accurate, and actionable data. And whatever this work involves, that it should be fair and sustainable. And so this is the dynamic involved with the leader who's doing the managed care contracting, is that you want to get in there and be an advocate for the other staff members that are going to have to measure these goals and keep this data and provide that standard of care. And that is not an unimportant thing, because you don't want to be in a situation where you've just signed off on everything and you really don't have the means to perform on the contract on in these areas. If we go to the next slide, some other relationship issues, of course, that we have, and any of us that are in healthcare are quite aware already of the decision-making, clinical decisions versus some other decisions that a hospital has to be involved with from a business and documentation point of view. And so that's a dynamic that's important in managed care contracts. And again, I advocate for, clinician being, freedom to practice within their range of abilities. And the other dynamic here is oftentimes the managed care organizations now will attempt to tap into your data regarding customer service and patient satisfaction. And here's another thing regarding the data. If you're a managed care contracting leader, you want to be able to have some consistency in the data that you're collecting. And you're going to have to be a leader on that for your organization, or maybe within your healthcare associations in your state, because the managed care organizations are going to set their own standards. And so, for instance, let's say a common chronic care area is managing the diabetic patients. Well, MCO-A may have different data collection requirements than MCO-B and MCO-C and MCO-D. And they also may have all different data collection standards for you to collect on patient satisfaction and customer service. And so I think it is within the range of reasonableness for the contractor, the managed care contract leader in a healthcare provider organization, to have a handle on these data requirements and to negotiate them to a fair level regarding the size and abilities of your rural organization. And I think those are important things, because again, you don't want to make life impossible for your clinical staff that are taking care of your patients from day to day. And you also don't want to have a situation where you're not performing at all on the managed care contract. The next slide, please. Local potential. Again, I believe I stated this earlier, and this actually takes a level of sophistication and that I haven't even done myself. But if you can work with your local third-party administrators, your local employers, and structure something, and your local Blues plan, structure something that makes sense in the rural environment, and have those local employers working with you and supporting your business as a hospital or a physician group, so that you're working reasonably with them, and there isn't a market for the for-profit Tennessee-based Medicare Advantage plan or whatever. But I will have to admit, this is a very sophisticated level of contracting, and I have never actually pursued it myself, but I see that as a potential, and maybe if you can't find your managed care contracts today, maybe you should leapfrog to looking at your regional market and what is the potential to work more directly with your local payers and employers. Okay, we're going to go to Roman numeral 3, section 3. And I think I'm going to be having to start buzzing through here pretty quickly. But negotiating managed care contracts. And one of the first questions comes from Shakespeare: to contract or not to contract. And really, I think that sometimes it's not worth contracting with a provider, and that it actually might be better to be out of network for particular providers. But that takes a sophisticated level of analysis that we're not going to get into here. And again, going back to contracting with your local supportive providers and employers and MCOs, maybe can leave you to be able to drop contracting with some of the other MCOs that are smaller in your market or not to your advantage to negotiate with. Next slide, please. So this is a list of the things to look at in your analysis as to whether you are going to contract or not contract. And you can look at these yourselves, and this really could be a webinar all in itself, where you're looking at the market share of your payer, the potential for growth of that market share, their financial stability. You know, if you've got a payer that's in financial trouble, which you can find those things out, that may be somebody you don't want to, a provider or an MCO that you do not want to bother to spend the time and resources to negotiate a contract. You want to look at your payer trends in your area and your state. Usually your state associations and Blue can give you a very good feel for that. Do you look at your local payer mix? You know, some organizations in rural settings in strong economies have a very, very nice local employer payer mix, which of course is the best paying typically in most markets. And so you don't have to depend quite so much on Medicare Advantage and some of those things. You want to look at your employer trends and your economic trends in your area and state. You're going to want to look at the actual reimbursement that's involved and all those other technical payer requirements we've talked about, like pre-authorizations and value-based data, because sometimes an organization just cannot, it's not valuable to put resources into the myriad of data requirements that some MCOs have. In the next slide, please, Cassidy. Common contract terms, and these are kind of little boring to me, because when I'm David, I probably won't be able to change these much at all. What are they covering? What's the scope of the contract? What are they requiring of me? Now, I might be able to get a little more reasonableness, say, on the utilization management, the pre-auths, the data collection here. That's something to, you know, plea for. The requirements of the MCO payer, typically us Davids don't have a lot of leverage to require much of anything. Usually financial terms, or we're kind of stuck with what we're given unless it's an unusual situation. Here we go, administrative operational issues, that's where I would take care, and then other legal considerations. Next slide. Common contract terms, and the only thing I'm going to emphasize here in the scope of the MCO contract is to have an understanding if this MCO is going to be selling its network and claims administration to other organizations, that you have an ability to have identified constantly if there are new payers connecting into this managed care contract. And that can be actually quite confusing. And sometimes it's fairly meaningless in a rural market, because they may be selling their network to somebody in your capital city, for instance, but say you're in the northern part of the state, 5 hours away from the capital city, where those other piggyback organizations don't really have much meaning to you in your rural market. Next slide, please. Again, this is a listing, and you'll see it also in the resources that I'm providing you here at the end of the slides. Probably the bigger thing here, again, I keep harping on this a little bit, I guess, is down third from the bottom, care management and coordination staffing, in order to get paid, frankly. Oh, another red flag is the 1, 2, 3, fourth bullet down. The MCO should really be using one of the national quality agencies to set their standards on quality. And if they're not, that's a red flag. Because those standards are set at sort of a national level by experts. And if an MCO is just setting up their own, that's a bit questionable. Next slide. Again, here, I'm just going to jump to the bottom of this slide. And again, the pre-authorization service list, what I'm seeing more and more is that pre-authorization, what is required to be pre-authorized is changing like weekly. And so I think it's important, even in the rural settings, to get a handle on what requirements for pre-authorizations there are in your managed care contracts, and somehow slow down or stop that they can only change the pre-authorization list, say annually or something like that, because unwatched, these MCOs apparently are doing whatever they want to your staff, and then you're getting denied, and because they may not be able to get the pre-auths done, or they aren't aware of them themselves. And so there you're just writing off business on that piece. Next slide. On this one, policies and procedures for denials and appeals, take a look at that. Again, rural providers often don't have much leverage on this, but if it's just totally unreasonable how much time you have to address a denial or the appeals process, you need to speak up as the managed care contractor leader and try to make those more reasonable. And I believe we're all aware that whereas before we'd have almost like 2 years to get a clean claim in, that's being shortened very, very much to 6 months or less. And so that really, again, gets into that revenue cycle and what we're doing to support our staff there, which is another entire topic, which we're not going to get into today. Next slide, we're just going to work through that. Is it already 1 o'clock, Cassidy?
No, you still have a few.
No, it must be. Here I'm in small town Iowa, and it must be the fire alarm that I'm hearing, and not the 1 o'clock bell. I'm sorry.
It's 12:48.
Rural. We're rural. Let's see. Yes, and the next slide, Cassidy, talks about, yes, extending the timeframes for your clean claim submission and stuff. It's actually noted on that slide. Okay, we're going to skip the next slide and go to the next slide, which is Roman numeral 3B5. There you go. Oh, you're good. And one of the things I want to note here is to be aware of, go back to 5. Yeah, thank you, Cassidy. Is in number 5, bullet point number 3, terms regarding ratings and rankings. You're going to want to be aware as to where these payers are, how they're ranking you, and where that's being publicized, and all of that, because you could have, and again, you're probably not going to be able to tell them what to do, although maybe you could negotiate being off the rating system for, say, the first year or something to give you time to meet the standards. But you're going to want to take a look at what they're doing and being aware of it anyway, so that, because you could be getting some good or bad press, whatever it is, it's good to be aware of it. Next slide, number 6, and here we have the takeaway. Be sure and take this away, is number 6, bullet number 2, the out clause. A very nice out clause where either party can terminate for any reason in a reasonable amount of time, and you can decide what that is. I think in managed care contracts, 6 months is pretty reasonable, but maybe you'd want it shorter, maybe you'd want it longer. But that is a takeaway. Always negotiate yourself an out clause. And some of the legalese and termination is just glazes my eyes over, and I'm a lawyer. So anyway, let's go to the next one, negotiating managed care contracts, C, negotiation techniques. And I think I do kind of need to get moving and get going with the Q&A. But these are the things that you want to think about in when you're working with negotiating with a managed care payer. And on the next slide, the reality is I try to be open and transparent and reasonable. Sometimes you'll find MCOs out there that are not reasonable, and then you kind of can't work with them. I would say 90% of them you can kind of be reasonable, particularly, again, those that are prominent in your market, like the Blues Plan or a local third-party administrator. But the reality is we're David and Goliath, and I come from the farm, and my dad taught me how, that's how I follow the money all the time. Follow the money, honey. And we, in any other business deal outside healthcare, I always know where my line is, where I will negotiate no further, and that I'm willing to walk away from the deal. And that would be nice to be able to do as a rural healthcare provider. But it's a little harder to walk away from these things and not contract with players, with MCOs. But again, know your market, understand what's going on, get advice from others who are in the business, your audit firm or your lawyer, and maybe there are some payers that you just walk away from, and you're not going to deal with them unless you have more favorable terms. Okay, next slide, Roman numeral 4. And these are areas involved in pre-negotiation. Okay, so this is a walk away. When you're negotiating a managed care contract, you don't just sign it and put it away. In fact, as part of the negotiations, you're involved with the areas that are going to be affected by the negotiations, like your revenue cycle manager, your CFO is going to want to analyze the reimbursement if it's unusual. You're going to want to have your utilization management and QA staff involved before the negotiation, so that you are educating and these other staff members are educating you what you can, what's reasonable to put in an MCO contract regarding these various functions and the data collection. So we're just going to buzz through here. If we go to the next slide, these are the areas that should potentially be involved in pre-negotiation. Areas in your organization. IT. You can negotiate anything you want, but if your IT isn't able to put it in place, you don't have anything. And this is a really, really sad thing that I see very consistently out there. And I will tell you, I don't know if it was following the money, honey, or what, but this is how I got a perfect score on an outside audit, is that I had worked with everybody in the organization on these new managed care contracts, and we were getting paid what the contract said we were getting paid, and that was the perfect score. And what I see is that somebody is negotiating these contracts, but then they're not doing the facilitation and education work and the basically setting up the managed care contract so that you can perform on it and make sure you're getting paid what you deserve. Next slide, please. During the negotiations, you're supported by others on staff as needed. Next slide, please. The contract setup. You share the contract with all areas involved. And maybe the payment reimbursement piece doesn't need to be shared with, say, the utilization review, quality of care nurse manager. But contract terms should be set up so that people can perform on the contract as needed. And what I find is sometimes the lawyer, in-house lawyer, or a lawyer, outside counsel, or the CEO, I don't know what the deal is, but they just hide them. And they don't even, I've seen places where the CEO has negotiated contracts and the CFO doesn't even have access to them. That's a huge mistake if you really want to get paid what you deserve to be paid. And so you need to do this contract setup and educate people so that they can perform on the contract with you. Next slide. We get into data elements. We'll just kind of skip through that because I think it is time to do Q&A, isn't it, Cassidy?
It is about that time.
Okay, and then if you skip to Roman numeral 6, there are a couple of pages, if you go on there, of what I identified as current really good resources for you to dig in on your managed care contracting work. And of course, there's always, I would think in every market, there are some professionals in an accounting firm or in your local healthcare associations that can help you and educate you on doing this managed care contracting when you find all those contracts or decide to renegotiate them. So now, Cassidy, shall we have questions?
Let's do. Thank you so much, Jean. That was wonderful. If you have a question, you may unmute yourself and ask your question aloud, or you can opt for the chat box and type your question into the chat box. You can address it to everyone, or you can look for my name, Cassidy Avila, in the drop-down box and send it to me, and I will ask it on your behalf. Okay, let's see. It looks like we do have a question. Okay, so the question is, what are the rules of forgiving or discounting patient responsibilities who is under a contract? I've understood that deductibles cannot be discounted or forgiven. Is this correct? What about copays or co-insurance?
I would say generally that's true because that is contractually required of the beneficiary, and you are intervening in the contractual relationship between the beneficiary and the managed care organization. And generally, yeah, you should not be discounting or eliminating those. And I don't know my legalese enough to give you, a real, logical, legal logic answer on that. But yes, generally you cannot forgive those.
Excellent. The next question we have is, how do you look at this from a quality position and collect data?
Well, it takes working with whoever is negotiating the managed care contracts and gaining access to the requirements for quality management and utilization review from each managed care organization. And oftentimes there's a lot of requirements. And so they may refer to their website that you would need to go study, and that those actual details are not necessarily in the managed care contract. Now, I think the person who's negotiating the managed care contract should still be looking at those and educating the utilization review and quality of care or call it QA staff persons on those things. And then beyond that, to learn how to deal with them, actually there should be a support person at the MCO organization that can help the provider QA staff persons understand what their policies and practices are and help them get set up and that kind of thing.
Excellent. Let's see.
Also, again, I believe there are various state level quality and utilization management associations and organizations that probably can be a resource of education and tips and that kind of a thing as well.
I don't see any other questions in the chat yet, but we will give it another minute or two. And I do want to remind you that we will be sharing the slides as well as a link to the recording on the core website, which is optimizingruralhealth.org. So you will be receiving that, if not today, tomorrow. And then if you think of a question after we end the webinar, please don't hesitate to reach out to us and we will do our best to get your question answered with Jean. Okay, well, it is 1 o'clock and I don't see anything else. So I think we will go ahead and adjourn. Thank you so much for spending this hour with us. Jean, thank you so much. That was really wonderful and we appreciate your time.
Well, thank you, everyone, for being part of this. I appreciate it. My pleasure.
Thanks, everyone. Bye-bye.
Hello.
Hi there. We will just give everyone